Imagine a scene that feels unmistakably American, yet it plays more like a horror film than a medical drama. A man slips in his bathroom and breaks his arm, not a rare accident. The pain is unbearable, so he calls 911, rides in an ambulance, gets wheeled into the has an x-ray, gets a cast, receives painkillers, and goes home. It all happens within a few hours, smooth, modern, exactly what you'd expect in a rich country. Then, 2 weeks later, the first envelope arrives, then the second, then the third. Each one is a separate charge, each one speaks a different language, and the total looks like nothing he has ever paid for the same accident anywhere else in the world. Online items are so absurd you laugh. A single bandage, a mysterious facility fee, a test no one seemed to ask for, a bill from a doctor you never even met, and another from the ambulance company that turns out to be outside your insurance network. And when you call to ask, the voice on the other end isn't rude often, it's very polite, but the answer keeps circling back to one point: that's just how the system works. The problem with American healthcare isn't a lack of good doctors, machines, or medicine. The US is home to world-class surgeries, top cancer centers, and research that changes lives. But precisely because the system is powerful, demand is huge, and money flows everywhere, it has become a pricing machine that ordinary people can't make sense of. Expensive isn't even the best word. The real feeling is illogical. You can't predict the price, you can't compare it, you can't negotiate, and you certainly can't say, fine, I'll go somewhere cheaper. The scariest part is this: when you need healthcare the most, you are the weakest customer in the room. To understand why US healthcare is absurdly expensive, you have to see it as a city built on stacked layers of history. Each layer was added to solve a problem in its own era, but when they pile up, the final result is a maze. You walk in to get treated, but you pay inside a labyrinth of insurers, hospitals, clinics, drug companies, provider networks, diagnostic coding, and fees so complex that merely explaining them requires an army of administrative staff. One of the biggest turning points didn't happen inside a hospital at all, it happened during wartime. When wages were controlled, companies that wanted to keep talented workers found ways to add benefits instead of raising pay, and employer-provided health insurance became an attractive solution. Then it received tax advantages, sank deep into workplace culture, and became the norm. A good job meant good insurance. From there, health insurance in the US didn't evolve as a unified public service. It evolved as an ecosystem tied to where you work, shifting by employer, by state, by contract, by benefits package. You change jobs, you change insurance, you lose your job, and you may lose your ticket into a healthcare system you assumed was a basic right. Even the way you enter the system creates a high-cost foundation. When you have hundreds or thousands of different insurance plans, each with its own rules, deductible levels, drug lists, and hospital networks, you can't run it with a simple process. Every hospital needs staff who call for approvals, hunt for the right codes to get paid, argue with insurers when a procedure is denied, and send bills in the exact format each company demands. Every great doctor doesn't just need nurses and equipment, they need an entire paperwork engine behind them. In this system, administrative costs aren't a side dish, they are an industry. But administration is only the surface. The deeper reason comes down to a simple question: in US healthcare, who actually pays and who actually decides? In a normal market, you buy something, you pay for it, you compare prices, you choose quality. In American healthcare, most of the time, the person receiving the service doesn't directly pay most of the cost. They pay part through monthly premiums, then add deductibles, co-pays, and co-insurance. The bulk of the real money flows from the insurance company to hospitals and doctors. That creates a separation between the consumer and the price. When you can't see the real price, you can't behave like a normal shopper. You don't go to the with a price comparison chart. You don't negotiate while struggling to breathe. And you can't wait for a discount when your child has a fever in the middle of the night. This is where the illogical part starts to grow. Healthcare prices in the US aren't formed like the price of a cup of coffee. They're more like the result of private negotiations between giants. Hospitals post extremely high sticker prices on paper. Insurers step in and say, "I'll pay less, but in exchange, you must be in my network." Hospitals respond, "If you want my name in your network, you accept my terms because your patients need me." The two sides wrestle. The patient stands in the middle and usually learns the outcome only after everything is already done. From that dynamic comes a strange phenomenon. The sticker price is almost never the real price, yet it's what determines the billing nightmare. If you have no insurance or you accidentally end up out of network, the paper price can fall like a hammer. Even if you do have insurance, the entire discount game makes you feel like you're being treated generously while, in reality, the system is operating on a price floor inflated from the start. Then comes another paradox. For the same service, at the same hospital, on the same day, two patients can be charged to completely different amounts simply because they have different insurance plans. In many industries, that would be seen as opaque and anti-competitive. In American healthcare, it becomes normal. Because prices aren't public information, they're trade secrets. So where is competition? The honest answer is, competition in US healthcare doesn't work the way people imagine. When we say market, we picture many sellers, many buyers, freedom of choice. But healthcare is shaped by geography and urgency. You don't choose a hospital because you prefer it. You choose it because it's the closest one when an accident happens. You don't choose the anesthesiologist in your surgery. You may not even know who they are. And in many parts of the US, the number of hospitals or hospital systems is large enough to dominate an entire region. Over the past few decades, waves of consolidation have pulled hospitals, clinics, and physician networks into massive systems. When one system controls a region, it gains pricing power. And when pricing power is held by a small number of sellers, the so-called market becomes distorted. On the other side, insurers aren't small players either. They are corporations that negotiate with scale, data, lawyers, and contracts as long as novels. They build in network provider lists, benefits packages, deductible structures, and a long menu of cost control mechanisms like prior authorization, limits on therapy visits, or forcing patients onto preferred drugs. These mechanisms are marketed as ways to keep costs down, but they also create more operating costs, more conflict, and more time ground away by paperwork. It can feel like a war between two giants, while you're the one holding an umbrella and trying to run through the arrows. But why are hospitals so expensive? How can a few hours of emergency care cost as much as a car? Part of the answer lies in how American hospitals must survive like businesses while being asked to function like public institutions. They have to keep emergency departments running 24/7, ready for everything from car crash to strokes. They must invest in costly equipment, meet strict safety standards, and hire highly trained staff. They also often absorb costs that aren't fully reimbursed, especially when caring for patients who can't pay. In many cases, hospitals cross-subsidize by raising prices where they can, especially in services paid at higher rates by commercial insurance. The result is that prices don't reflect the true cost of each individual service. They reflect an all-out struggle to balance the books in a fragmented payment world. Then we reach another crucial thread: how healthcare gets paid for. Many parts of the US system run on fee-for-service logic. Do something, bill for it. One more scan, more money. One more test, more money. A more complex procedure, a higher billing code. This creates an incentive to increase volume, increase procedures, increase medical output. Many doctors and hospitals aren't malicious, they follow standards, clinical habit, and a fear of missing something serious. But when the payment structure rewards doing more, the system naturally leans toward doing more, and the more it does, the bigger the bill becomes. Now look at another character in this story, the pharmaceutical industry. The US is the largest drug market in the world and also a place where drug prices can be significantly higher than in many other developed countries. One reason is that the system allows new drugs to be priced very high, especially when they're under monopoly protection, when patents and barriers to competition are still in force. Another reason is the complex chain of intermediaries, drug makers, distributors, pharmacies, pharmacy benefit managers, and insurers. In that chain, hidden rebates and backroom deals can push list prices up, then bring them down for whoever has bargaining power. Patients may end up paying closer to the list price through percentage-based cost sharing, or when a drug isn't on the preferred formulary. The absurdity deepens, same pill, same ingredient, but the price depends on which corner of the maze you belong to. If drugs are one piece, emergency services and out-of-network care used to be one of the most infamous traps. You go to an in-network hospital, but a doctor involved in your care turns out to be out of your insurer's network and you get a surprise bill. This made American healthcare feel like an airport where everything can become an extra fee. Even if recent years have brought efforts to curb surprise billing, the underlying problem remains. You can't control all the links in the chain of your care. Yet you're forced to shoulder the financial consequences as if you had chosen each service deliberately. Then there's a factor that's harder to talk about, but very real: fear of lawsuits and a defensive culture. In the US, doctors work in an environment where mistakes can carry heavy legal consequences. That can encourage just-to-be-safe medicine, ordering extra tests to eliminate risk, writing thicker documentation to protect oneself. Not every test is unnecessary, and you can't simply say it's all lawsuits, but in a system already shaped by fee-for-service incentives and administrative complexity, defensive medicine adds another stream into the river of costs. Another thread is labor costs. The US trains doctors for a very long time. Many carry large student debt and work under intense pressure. Pay can be high in many medical roles, especially in certain specialties. That reflects labor markets, training structures, licensing, and shortages in some areas. But the paradox is, even if doctor pay is high, it still doesn't fully explain why bills balloon into the illogical. Because you're not only paying the doctor, you're paying the entire machinery around the doctor: administration, coding, negotiation, compliance, management, technology, insurance, profit, and the cost of slicing care into hundreds of separate charges. Return to the opening moment. You hold the bill and see unfamiliar language. Why do medical bills in the US look more like tax filings than receipts? Because the system must translate care into the language of payment. Every visit, every procedure, every diagnosis must be coded. That code determines who pays, how much, whether it's denied, whether prior approval is required. When coding becomes the center of gravity, a significant portion of healthcare's energy shifts from treating illness to proving you treated it in a way that qualifies for payment. The irony is sharp. Modern medicine helps people live longer, yet the payment system makes people age faster from stress. So the high cost of US healthcare isn't just expensive, it's expensive because of friction. Friction at every junction between institutions, hospitals and insurers, doctors and insurers, pharmacies and pharmacy benefit managers, hospitals and device suppliers, government and private systems, state and federal layers. Every junction has contracts, regulations, and exceptions. Every exception needs someone to handle it. Every person handling it becomes a cost. And that cost returns ultimately to the final bill. But if things are that bad, why does it still exist? This is the why that becomes deeply political and social. Because American healthcare isn't just a service, it's a massive structure of interests. Some groups benefit from high prices, providers with market power, certain hospital chains, intermediaries, segments of pharma and medical devices. Others fear change because of risk, People who currently have strong employer coverage worrying that reform could make their situation worse, even if they know the overall system is broken. There are ideological battles over the role of government, freedom of choice, taxes, and who should pay. And because healthcare is tied to life itself, every change is sensitive. You can reform transportation and people complain, reform healthcare and people panic. Another paradox is that many Americans experience healthcare as both amazing and horrifying at the same time. When you reach the right hospital, meet the right doctor, and get treated at the right moment, you can be saved by world-leading medicine. But when you leave the hospital, you enter the financial system of healthcare, and that is what can break people. The illogical feeling isn't in the operating room. It's at the desk where you try to understand why one procedure generates 3 different bills, and why what you owe depends on things you never controlled. So what are the consequences? First, insecurity. In many developed countries, illness is mainly a fear about health. In the US, illness is also a fear about finances. People may delay care because they fear the cost, take less medication to stretch a prescription, or skip routine checkups until the disease becomes worse. A system that's expensive in unpredictable ways pushes people into defensive behavior. And when defensive behavior becomes a social habit, public health erodes quietly over time. Next comes the burden on businesses and the labor market. When insurance is tied to employment, companies become buyers of healthcare for employees, and those costs affect wages, hiring, and competition. Workers can become stuck in a job simply out of fear of losing coverage, an invisible kind of lock-in. That reduces economic flexibility and turns healthcare into part of the story of productivity, not just the story of health. Then there's inequality. If you have money and strong insurance, you have more options, faster access, and less financial erosion from bills. If you're poorer, live in an area with fewer choices, or fall into a gap in coverage, you're more likely to be crushed not only by illness, but by the bill that follows. And healthcare inequality cycles back into social inequality: worse health, reduced ability to work, lower income, and the loop continues. If you're waiting for a single master villain to blame, you'll be disappointed. US healthcare is expensive not because one evil figure stands behind the curtain. It's expensive because of misaligned incentives, patchwork history, concentrated bargaining power, lack of transparent pricing, payment systems that generate friction, and intertwined interests that make change hard. The illogical outcome is, in fact, the logical consequence of each piece acting rationally on its own, but when assembled, the overall machine becomes a cost-producing engine. Is there a way out? Yes, but there's no clean, quick exit. Commonly discussed directions include expanding price transparency so consumers and employers can compare better, limiting out-of-network traps and surprise fees, shifting payment from fee-for-service to pay-for-outcomes to reduce incentives for doing too much, strengthening competition by controlling excessive consolidation, and creating simpler insurance options that are less fragmented. But every direction touches someone's power, so every direction triggers resistance. The most important thing to face is this: healthcare is not like ordinary shopping, so it can't be expected to become a perfect market on its own. When you're in pain, you don't have the time to be a rational consumer. So if society wants healthcare to feel less absurd, society has to accept redesigning the rules, reducing pricing power built on secrecy, reducing administrative friction, and reducing the sense that every hospital visit is a gamble with your financial future. Back to the man with the broken arm, the deepest pain isn't the bone, a bone can heal. The deepest pain is the feeling of being lost inside a system you don't understand, didn't choose, and can't escape. You live in a country with world-leading medicine, and yet you face a question that sounds strange in many other places. Can I afford to see a doctor? If a society forces people to weigh health against bankruptcy, then what's expensive isn't only money, it's trust. And maybe that's the coldest conclusion of all. US healthcare is absurdly expensive because it wasn't designed as a straight road from patient to treatment. It is a maze built from history, interests, and bargaining power, Hospitals still save lives. Doctors still treat disease, science still advances. But the financial layer wrapped around all of it has turned healthcare into a product that is both essential and hard to reach, both magnificent and ruthless. When you look at a bill and say, "How can this be so absurd?" you're not wrong. You're simply seeing the surface of a machine that, for decades, has learned how to turn life into numbers and turn those numbers into a game most ordinary people can't win.